Medical Service Company has made treating patients with sleep-disordered breathing a top priority. That's why we created MSC Sleep, a division with a commitment to investing in technology, clinicians, and processes to create a best-in-class experience for our patients and partners. At MSC Sleep, you get the best choice for CPAP therapy. We expedite care to ensure patients receive their critical sleep therapy equipment fast. High-touch clinical care provides industry-leading compliance rates. Individualized communication for both the patient and the provider offers transparency from prescription referral to PAP therapy setup. And finally, MSC has an internal team of over 30 sleep coaches making live outreach daily to assist patients throughout their PAP therapy journey. On behalf of Medical Service Company and all our partners for this event, we hope this forum provides information that will help you provide better care for sleep-disordered breathing patients across the entire nation. To learn more about our MSC Sleep program, please visit us at medicalservicecode.com or call 866-90-SLEEP.
Good afternoon, everyone. We hope you're enjoying a full day of sleep and respiratory education so far. This afternoon, we will provide sleep and specific lectures based on your enrollment in the sleep track. The speaker lineup is designed to further enhance your knowledge in sleep medicine. Starting off the sleep track is none other than Dr. Asim Roy. He'll be speaking on emerging therapies. Currently practicing at the Ohio Sleep Medicine Institute in Dublin, Ohio as medical director, Dr. Roy works in close collaboration with healthcare providers to deliver continuous and coordinated sleep medicine care to adult and pediatric patients. He brings a thorough and thoughtful approach to patient care, in line with the comprehensive standards of the Institute. Dr. Roy is very involved in research related to sleep medicine and has served as the primary and sub-investigator on multitude of research trials. He has authored various publications on topics such as sleep and neurological disorders, restless leg syndrome, idiopathic hypersomnia, sleepwalking, and more. Not only has he participated in many industry-specific consulting and speaking events, but he also continues to provide media presentations and editorial services, in addition to serving on a variety of committees. As someone who is a big proponent of education, Dr. Roy also trains medical professionals in sleep disorders management. He serves on the board of directors for the Committee on the Accreditation for Polysomnographic Technologist Education. He is a member of the American Academy of Sleep Medicine, American Academy of Neurology, American Medical Association, and Columbus Medical Association. Thank you to Dr. Roy for presenting again at our forum. As you listen to the upcoming lecture, feel free to submit your questions to Dr. Roy under the Engage tab. Don't forget to complete and submit your evaluation for each lecture.
Hello, my name is Asim Roy. I'm Dr. Roy. I am medical director at Ohio Sleep Medicine Institute based near Columbus, Ohio. I am clinical assistant professor at Northeast Ohio Medical University, and I am happy to be here. It's, I think, my second time presenting at this education forum. And this year, I will be talking about differential diagnosis of excessive sleepiness. That's an area of interest of mine. It's an area I think you all will see in your day-to-day work of seeing patients with sleep apnea and other sleep disorders, where sleepiness is a big issue for a lot of these people. So today's learning objectives, we're going to learn about the definition of excessive sleepiness. We're going to learn about the different causes of excessive sleepiness, and what kind of objective tools are there to identify excessive sleepiness. So when we talk about excessive sleepiness, it's basically the reduced ability to stay awake and alert during normal daytime hours, which then results in lapses of sleepiness or sleep. So people are kind of intermittently falling asleep, could be micro sleep, may not be fully dozing off, but these are kind of interfering with their daytime alertness. And some people don't even say they're falling asleep, but just feel tired or sleepy. Excessive sleepiness definitely reduces quality of life for affected individuals, and it's estimated to be present in about 10 to 20% of the entire US population. So it's very, very common. When we define excessive sleepiness, it must be present for at least 3 months and occurring at least 3 times per week. That's how frequent it has to happen. There are 2 exceptions, and these are 2 diagnoses we make. One's called recurrent hypersomnia, and then another one called hypersomnia due to drug and substance intake. These are 2 situations where the 3-month, 3 times per week rule does not apply. The other question we often ask, is there like a timing relationship between the onset or exacerbation of the sleepiness? Are there things that correlate with when the sleepiness comes on? Is there also a family history of sleepiness? Are there any other associated features or diagnoses, such as like other medical conditions, other psychiatric conditions? Are they on any medicines that may be affecting them? So it's important to kind of take a very holistic approach at trying to figure out what's causing their sleepiness. It may be due to multiple things too. So one of the key differentials that we're going to talk about is probably the most common cause of sleepiness in the United States is behaviorally induced insufficient sleep syndrome. In essence, you're just not getting enough sleep. And I'm sure most of us have suffered from this, either hopefully not chronically, but at some point in our lives. We all stay up late and wake up early or have an early flight. Things like that can cause insufficient sleep. And this is basically, again, often seen when people are not getting enough sleep during the work week or during the weekdays, and then adding extra few hours of sleep on the weekends to make up what they didn't get during the week. A way for us to verify if someone's not getting enough sleep is either using sleep logs, which are subjective, or actigraphy, which is what we end up relying on quite frequently because it's a little more objective. Potentially wearables are another way to help potentially identify this concern. There is a group of people that are what we call long sleepers, and they are technically not a disorder as long as they're getting enough sleep. So these individuals typically need 10, 11, 12 hours of sleep, much longer than the average sleep duration. And what is key in this history is when they are getting that 10, 11, or 12 hours, they don't feel sleepy. They don't have trouble waking up. They're not doing weird automatic behaviors as long as they're getting enough sleep. They tend to present because they're no longer able to get the 10 or 11 or 12 hours that they need. They're restricted because of work or school or whatnot, and that's when they become symptomatic. But when they get enough sleep, they actually feel normal. And so versus someone with a sleep disorder, even getting more sleep often doesn't make them feel better. When we talk about chronic insufficient sleep, again, this is something that we kind of briefly touched on earlier. Nocturnal total sleep time should be determined before you make a diagnosis of a central hypersomnia. So when you say someone has central hypersomnia, it means their sleepiness is coming from their brain from a pathologic condition. But before you make a diagnosis like that, you really need to be sure someone's getting enough sleep before we blame it on anything else. So anyone who's getting less than 7 hours of sleep can cause excessive sleepiness that can mimic someone with narcolepsy, someone with idiopathic hypersomnia. So it's really important to know, are they getting enough sleep? Again, sleep log and diaries are useful. Actigraphy, very useful. Again, not always readily available. Again, I am relying on wearables a little bit more than I used to, just because more and more patients are wearing these things. The other thing to help separate this group out is if they're not getting enough sleep, you have them get more sleep. So we do what's called a sleep extension trial for about 10 to 14 days. And that's basically saying, all right, for the next 2 weeks or so, I want you to get 8 or 9 hours of sleep regularly. And if you don't feel better after doing that, that's when maybe something else is going on here. But it's important to know for sure, are they getting enough sleep first? Substance-induced hypersomnia, which we briefly talked about, which does not require the 3-month or 3 times per week rule. This is usually obvious. Their sleepiness is secondary to the use or abuse of illicit drugs, over-the-counter prescription medicines. And again, a lot of medicines cause sleepiness, right? Antihistamines, benzodiazepines. And sometimes, if they've been on some sort of abuse of stimulants or cocaine or anything that's kind of what we call an upper, and they discontinue it abruptly or just discontinue it, they might show sleepiness now because they're not getting that stimulation that they were before. Again, it's important to do a drug screen in these patients to make sure you're not, again, missing some of these illicit use or other things that might be causing their sleepiness. So one of the diagnoses out there that for me, often gets overlooked is something called upper airway resistance syndrome. And this is kind of the early form of obstructive sleep apnea, but again, often gets overlooked. So the airway is collapsing, but not all the way. So if we think of an apnea or a hypopnea, typically you're saying if there's a 30% or 50% or more reduction in the airway. In individuals with upper airway resistance syndrome, they're not quite collapsing their airway that much, maybe 10, 20, less than 30% typically. What else is also noted is these individuals typically don't have a desaturation associated with it. So their oxygen levels stay fairly stable, maybe drop 1, 2%, but usually aren't dropping as much as someone with apnea or hypopneas. So it gets challenging to diagnose this group because it's really tied to their arousals. So the restriction in the airflow results in resistance in the airway, which then results in a micro arousal or micro awakening. And again, most of these patients don't even know this is going on. It's often undetected, but they wake up exhausted. They wake up tired. They don't have enough energy through the day. So they kind of have the same symptoms as someone with sleep apnea. However, they don't meet the criteria for OSA because their airway is not collapsing enough. Many of these patients eventually develop obstructive sleep apnea as they get older, age, or gain weight. But it's helpful if you can identify this patient pool earlier to help not only help them feel better, but maybe kind of stabilize their disease state. Probably one of the most common things tied to traumatic brain injury is post-traumatic hypersomnia. So many people who suffer a TBI will suffer sleepiness after the brain injury. And it's estimated at least 28% of these patients suffer with sleepiness. And they feel it could be due to many different things. So maybe they had a sleep disorder that was undiagnosed prior to the brain injury, and the brain injury just brought it out to light or made it worse. It could be from the medicines that are being used for the brain injury. It could be the direct insult of the brain injury. There is known effects from direct injury, shear injuries to the orexin neurons. These are the wake-promoting neurons in the brain, or other wake-promoting areas within the brain that may be affected by a traumatic brain injury. So there's multiple potential reasons why someone may be sleepy after a TBI. We also know sleep disordered breathing is present in about 25% of patients with traumatic brain injury. And again, it's hard to know if it's the chicken or the egg, but we suspect there are many patients that had the sleep apnea before the TBI. The need for sleep or daytime lapses need to be, again, occurring for at least 3 months. And for a lot of TBI patients, it can last up to a year after the injury. What else has been reported in the literature is if you measure orexin levels or hypocretin levels, that neurotransmitter in the brain that helps you stay awake, they can be low for months after a TBI. So the only way to measure that is through a spinal tap. So that's not readily done today. Another disease that often has sleepiness associated with it is Parkinson's disease. Obviously, you should probably know if they have a Parkinson type disorder, but almost half these patients, upwards of half of these patients, will suffer some degree of excessive sleepiness. We know Parkinson's has a direct effect on the wake promoting neurotransmitters. So there's a negative impact from the disease itself on those areas of the brain. We also know Parkinson patients are at higher risk of sleep apnea, higher risk of restless legs, periodic limb movement disorder. These are all been linked to Parkinson's disease. We also know if they fall late in the disease, they often go into REM sleep very quickly. And so that may be a phenotype of a narcolepsy type picture as well. And we know the medicines used for Parkinson's, like the dopamine drugs, exacerbate sleepiness, and it's often dose dependent. Another disorder out there, an autoimmune condition that often has fatigue or sleepiness associated with it, is multiple sclerosis. We know different sleep disturbances are common in MS. We know sleepiness can be confounded with fatigue because fatigue and sleepiness can be challenging to separate out. We don't believe orexin or hypocretin neurons are affected in MS unless there's a direct lesion in the hypothalamus, which is atypical. So again, from a orexin or hypocretin effect, it's probably intact in patients with MS. Both multiple sclerosis and neuromyelitis optica or DeVick's disease have hypothalamic lesions. And therefore, in those groups, specifically the neuromyelitis optica, this is a much more severe form of the autoimmune condition here, can result in excessive sleepiness. And then restless leg syndrome is definitely much more common in MS than the general population. We know sleepiness can occur after a stroke. Again, it typically correlates with where the stroke has happened or the size of the stroke. Typically, the larger the stroke, the more likely the individual is going to be sleepy. And it can be tied to sleep disordered breathing. A lot of patients with stroke have sleep apnea prior to the stroke, and some develop it after the stroke. So it's important to rule out sleep apnea in this population as well. And then if there's other neurologic disorders out there that can cause sleepiness, one that's been well established in the literature is encephalitis. So someone who has kind of inflammation due to a virus or bacteria or some sort of maybe autoimmune process can have inflammation in the brain that may cause sleepiness. We know occasionally brain tumors can cause sleepiness. Hydrocephalus, where the areas of the fluid in the brain get swollen up, can cause daytime sleepiness, sometimes is the presenting symptom. So if it's brand new sleepiness out of the blue, it's sometimes something to think about. Again, not very common, but definitely on the list of things to be aware. There can be other neurologic signs, but may not be. Sleepiness may be the only symptom that presents itself. Sleepiness from other medical disorders are very common. We know that patients with chronic pain or frequent awakening secondary to other underlying medical conditions, such as congestive heart failure patients wake up a lot to go to the bathroom, are just very fragmented in their sleep. Pain makes people's sleep very fragmented, can cause secondary sleepiness. Other autoimmune conditions like thyroid disease, rheumatologic conditions like rheumatoid arthritis or lupus, things like that can cause fatigue or sleepiness. So making sure you're thinking about all these other conditions when someone's sleepy is important to take into account. Again, it could be multifactorial. We know depression can present with kind of a sleepiness type picture. And maybe the presenting feature of primary depression. We know people who have central hypersomnia, who might have narcolepsy or have idiopathic hypersomnia, are at higher risk of depression as well. So you definitely want to rule in or rule out any psychiatric comorbidities or disorders. You definitely want to get a thorough history to see what might be contributing to the depression or causing it. We know people with depressed mood have low energy, feel agitated, have altered appetite, can't concentrate, decreased sexual function, guilty feeling, and again, obviously in severe cases, may be suicidal or have delusional thoughts. So looking at all these other history is important to help identify, is this due to depression or something else? Probably the most common sleep disturbance in someone who has like a melancholic depression is poor sleep. And a lot of these patients have trouble getting to sleep or maintaining sleep or wake up earlier than they want. This leads to tiredness, but may not be true hypersomnia of central origin, may not be from the brain due to like a narcolepsy type picture. We also know hypersomnia is associated with increased appetite or weight gain. So it could be presenting in an atypical depression type picture. Again, trying to find the timeline of when all these things started can be helpful to identify what's causing what. We know hypersomnia can be linked to people who are just dysthymic, just kind of a low-grade mood disorder. This typically presents later in life, but it can happen earlier. And again, sleep disturbance due to mood disorders like anxiety or depression are related to kind of a hyperarousable phenomenon. So these brains wake up more frequently, fragment their sleep, leave them more sleepy during the day. What's interesting, though, if you do some objective testing, and we'll dive into this a little bit later too, is the multiple sleep latency test, the test that we do 5 naps throughout the day. They're 20 minutes in length, typically. We want to see how quickly does someone fall asleep. This helps us rule in narcolepsy or something like that. People who are depressed and sleepy typically don't fall asleep very quickly on the MSLT. So it's one way to rule them out of the picture. Circadian rhythm sleep disorders are another one that can be causing sleepiness. These are people who are most commonly night owls. They go to bed after 2, 3 in the morning. They have a delayed sleep phase. And again, they're hard to wake up in the morning and typically are hard to get going. They snooze a lot and they have challenges. What is interesting in their history, though, is once they kind of get going and have the afternoon, they kind of feel more awake the second half of the day. And really, again, can't fall asleep till later at night. So it's important to kind of gauge their sleep history and kind of identify, are they sleeping in on the weekends, and during the week they have to wake up early, which is making them have a hard time getting going. And then again, do they get kind of a second wind phenomenon later in the afternoon or early evening, because that's kind of when they feel the most awake. Narcolepsy, again, not I mean, it is relatively rare, but more common than we used to think. It's estimated about 1 in 2,000 people have narcolepsy. It is a disabling sleep disorder. Sleepiness is the hallmark feature, and some of these patients have REM-related phenomenon. The one that's most distinguishing is something called cataplexy. This is where individuals feel weak, either in their knees or in their hands or in their face, due to an emotional state. So if they're laughing a lot or angry, suddenly they get this weakness that comes on. Again, it could be just in their hands, it could be their face sagging, it could be very subtle, but that is their cataplexy. The classic cataplexy most people hear about is the knee buckling, they fall to the ground. But again, a lot of patients don't have that extreme form of cataplexy. And sometimes you can suppress the cataplexy, if they're not laughing too much, they kind of control their emotions. Maybe they're already on an antidepressant. Antidepressants can help treat cataplexy. So you may not be getting that history very easily. Sleep paralysis is a REM-related phenomenon, a dream sleep-related phenomenon. Remember, during REM sleep, your muscles are paralyzed. That's normal. However, in sleep paralysis, your body's trying to wake up, but still stuck in that paralysis and REM sleep. So you're kind of trapped in two worlds, and that's what causes that phenomenon. Hypnagogic or hypnopompic hallucinations, kind of as you're drifting off to sleep, are you seeing something or hearing something that's there, like a dreamlike state, but you're partially awake and partially asleep? That's kind of going into REM sleep too quickly. And again, this is how we diagnose them or help support the diagnosis, is when we see that MSLT, that multiple sleep latency test, they typically go into REM sleep at least in 2 out of those 5 naps, and that can help firm up the diagnosis. Again, normally it should take 90 minutes to go into REM sleep. In people with narcolepsy, they typically go into REM sleep in less than 15 minutes. When we separate narcolepsy into 2 types, there's type 1, which is the one with cataplexy. We clearly know this is an autoimmune condition. We believe it's been linked to both strep, influenza A, H1N1, potentially even the vaccines to H1N1. We'll see if COVID, it's unclear if COVID causes an increase in narcolepsy risk at this point, but we know it's an autoimmune condition triggered by an infectious process, whether it's a virus or bacteria, and slightly associated with the genetic marker, which are these HLA antigen markers that tell us what type of genetic makeup you have on these immune cells, and that puts you at risk of developing narcolepsy. Again, cataplexy can be mistaken for syncope or seizures because, again, if you have that full-blown form where you collapse to the ground, what's interesting is though people with cataplexy are aware of their environment during that time. So they don't lose consciousness, they just lose complete muscle tone. Type 2 narcolepsy is basically the same as type 1, except just no cataplexy. The other thing is we're not clear on what's causing type 2 narcolepsy. We know in patients with type 1, they don't make any more orexin or hypocretin neurons, so they don't make enough of that neuropeptide that helps keep the brain awake. Again, the most common symptom associated with narcolepsy is excessive sleepiness. It's by far typically the most bothersome symptom. Objectively, the way we identify these patients is through an overnight polysomnography, the overnight PSG, followed by the MSLT, the multiple sleep latency test, the 5 naps throughout the day. One of the things we look for on the overnight PSG, do they go into REM sleep too quickly? That can be one of the 2 that are needed to diagnose this patient pool. We also want to make sure they don't have apnea or periodic limb movements or anything else that might be disrupting their sleep. And again, typically when they stay for that nap test, they're falling asleep in less than 8 minutes on every nap, and they go into REM in 2 of the naps. Again, it can be challenging. Some of these patients don't go into REM. They can still have narcolepsy. It's not a foolproof test. And if they're on an antidepressant, it makes it even harder to identify the REM sleep too. So these are all variables to think about that may be why a false negative result may occur on an MSLT in someone with narcolepsy. More recently, in the last few years, we're able to do CSF, spinal fluid analysis, in type 1 narcoleptics. And these patients will have low or absent levels of orexin or hypocretin in their spinal tap. And so it's a good way to maybe help firm up the diagnosis of type 1 narcolepsy. And again, that can be measured in the spinal fluid today. There is HLA testing, which is that marker on those immune cells, that antigen marker. And this DQB10602 has been strongly linked to type 1 narcolepsy, but not really helpful for type 2 narcolepsy. And it's also interesting, 30% of the general population has this marker as well, but not everyone gets narcolepsy. So this is why we believe it's due to this immune response, due to an infection that triggers this whole cascade. And again, one of the key clinical history in narcolepsy is the naps. When patients nap in narcolepsy, they tend to be shorter, 20, 30 minutes, or sometimes 45, and they tend to be more refreshing. Another diagnosis that's on the differential is idiopathic hypersomnia. And there's two types. There's the long sleep phenotype and the normal sleep. The classic idiopathic hypersomnia patient typically have the long sleep duration. That means they need at least 11 hours of sleep or more. What is interesting is they never feel alert and need a lot of help getting up in the morning. This morning inertia, we sometimes call this sleep drunkenness. It's kind of this inability to get going. They need to snooze 3, 4, 5, 6 times. We have patients where their family members come in and actually throw cold water on them to wake them up. So it can be very hard for them to get going in the morning. And that can last minutes, it can last hours. What else is typical in these patients? They tend to take longer naps, 2, 3 hours, and don't feel any better. Actually, sometimes feel worse. So a lot of them will try to avoid a nap because they don't feel better after a nap. Many of them will have a circadian rhythm to them where they are a little more delayed. That's not specific to IH necessarily. And a lot of these patients complain of brain fog and mental fatigue. And again, on their MSLT, they will fall asleep in less than 8 minutes typically, but they won't go into REM sleep typically on any of the naps, definitely less than 1 for sure. And some of these patients, we will do actigraphy to see, are they sleeping 11, 12 hours pretty consistently to help know, are they in that long sleep phenotype. Recurrent hypersomnia, and there's basically 2 that fall under this category. One's called Klein-Levin syndrome, and the other is called menstrual-related hypersomnia. Basically, it's sleepiness, excessive sleepiness that lasts at least a couple days, up to 28 days, and that occurs at least once a year. And what's interesting is when these episodes occur, when they resolve, and they resolve spontaneously typically, if they have another attack, in between these attacks, the person's completely asymptomatic. They have no symptoms at all. It's only in that window of time do they have this excessive sleepiness. And it's very rare to see someone with Klein-Levin syndrome. And usually the menstrual-related hypersomnia is pretty clearly evident that their sleepiness comes on right around their cycle. Again, Klein-Levin syndrome, excessive sleepiness that can last a couple of days, usually a couple of weeks. When they are awake, so they might be sleeping 16, 18, 19 hours or more. When they wake up, they're sometimes very voracious. They have compulsive eating. Sometimes they have sexual disinhibition. They're hypersexual. They have odd behaviors. They don't remember things, kind of have confusion and hallucinations. So when they're awake, they're in an odd state. And when they go back to sleep, they're kind of in this hibernation state. Again, the menstrual-related hypersomnia, the sleepiness typically occur somewhat similar to Klein-Levin in terms of the severity of their sleepiness, may not have all the other features, but again, time sync to their menstruation period. So what are some of the objective tools that we rely on to help identify what's going on? Again, sleep diary and sleep logs are very helpful. This is, again, subjective. Patients kind of have to record their own daily sleep patterns. We usually have them do it for at least a week, usually up to 2 weeks. We have them ask, what time are you going to bed? How long is it taking to fall asleep? Did you wake up during the night? How long did it take you to fall back asleep? What time did you wake up? Did you take any naps? When did you eat? These are all things that kind of help identify what their patterns are over a couple week stretch. Probably the most common questionnaire that we use, and you guys are all probably familiar with, is the Upward Sleepiness Scale. These are 8 questions on a scale of 0 to 3. 3 meaning you're definitely going to fall asleep. 0 means you're not going to fall asleep on these questions. And it basically just assesses how sleepy is an individual based on these scenarios. So like sitting and reading, sitting lying down after lunch in the afternoon, sitting in a meeting. These are kind of scenarios. What's the chance of you dozing off? And anyone who scores more than 10 out of the 0 to 24 scale typically is considered a sleepy individual. It also can help someone separate them out from a fatigue problem than a sleepiness problem. This does not help you diagnose what they have. It just tells you they're sleepy. Another scale we sometimes use is called the Swiss narcolepsy scale. It really is just helpful to pinpoint type 1 narcolepsy and nothing else. And then there's a more recent scale, the idiopathic hypersomnia severity scale. And this, again, does not help you diagnose idiopathic hypersomnia, but really helps you identify how bad are their symptoms at baseline and then track them over time as you treat them. So it can kind of help you guide, are you making some improvements in their symptoms? When we talk about actigraphy, this is kind of a watch someone would wear. It tracks basically their sleep-wake patterns. It's like using a wearable, except it's FDA approved. It uses an accelerometer, basically just moving kind of the motion. And it also has some light data. We can know how much light's in their environment. And it helps us, again, really hone in on anyone who's not getting enough sleep or getting too much sleep or who has a circadian phase issue. Polysomnography, which you all are familiar with, again, helps really rule out other causes of sleepiness or other sleep disorders. We know it measures multiple different functions. We know sleep stages from EEG recording, breathing patterns, whether they're obstructive or partial or central, snoring levels, blood oxygen levels, cardiac rhythm, body position, and limb movements. More recently, in the last 5-10 years, we know we've been doing a lot more home sleep testing. Again, it's really designed to look for sleep disordered breathing. Really cannot be helpful at this time to rule out central hypersomnias. Maybe in the future, there'll be wearables or home sleep testing that can help identify someone who has narcolepsy. But as of today, this is really designed to identify patients with sleep apnea and different types of sleep apnea. The multiple sleep latency test, again, many of you are familiar with this. It measures how long it takes someone to fall asleep during a nap. These typically occur every 2 hours after someone wakes up after an overnight polysomnography. And these are 5 naps throughout the day. And the question is, how quickly can you fall asleep? They're placed in a dark, comfortable environment, usually in the bed, relaxed. They don't have all the hookups to them as they did on the overnight study. And again, we're looking for how quickly do they fall asleep and do they go into REM sleep at all? Anyone who's considered pathologically sleepy if they fall asleep on average in less than 8 minutes on all 5 naps. And then patients with narcolepsy will typically go into REM sleep at least in 2 out of those 5 naps. Now, if they go into REM sleep on that overnight polysomnography, you can use that as one of the two that are needed for the diagnosis of narcolepsy. Again, this can help separate someone out from narcolepsy type 2 to idiopathic versus idiopathic hypersomnia. Again, lab test, it's important to make sure you're ruling out other causes. So thyroid levels, vitamin levels, iron deficiency, urine tox screen may help you identify other potential causes of sleepiness. Again, urine test is something we do routinely, drug screen test, especially done during the MSLT to make sure they're not abusing anything during that time, which may give us a false positive or false negative result. CSF analysis is more recently available. Again, it's really helpful in patients with only type 1 narcolepsy. We can actually measure the orexin or hypocretin levels and know where they are with how much they're making in their brain. Again, type 1 narcoleptics make minimal to no orexin or hypocretin level in their brain at all. So a few questions to finish off and a couple vignettes, and then we'll be done. So what test would help you differentiate an individual complaining of excessive sleepiness with depressive disorders versus someone with narcolepsy type 2? A, would it be actigraphy? B, would it be EEG? C, would it be HLA testing? Or D, would it be the MSLT? You guys a few seconds to think about this. And the answer is D. The MSLT is really our best tool to help separate someone with depression from someone with type 2 narcolepsy. Remember, if you're depressed and sleepy, you typically won't fall asleep on the MSLT as quickly as someone with narcolepsy type 2. The actigraphy would not really help diagnose depression or narcolepsy. The EEG is really not helpful for either of these, except if they had seizures or something else you were considering, or dementia. HLA testing, again, is only really helpful for type 1 narcolepsy. Again, they should have a history of cataplexy at that point. What test can be helpful in narcolepsy type 2? A, HLA typing, B, a tilt table test, C, a CSF hypocretin, D, A and C, or E, none of the above. Give me a few seconds to think about this. All right, E, none of the above. So really none of these tests can help you diagnose type 2 narcolepsy. HLA testing does not. Tilt table really is looking for either like orthostatic hypotension where the blood pressure drops, some vasovagal type phenomenon. CSF hypocretin, again, helps you in type 1 narcolepsy. So really none of these are very helpful. And we'll finish off with a couple vignettes here. Here we have a 16-year-old male was recently found to be falling asleep in his math class at 8 a.m. His teacher was upset, told his parents. On further questioning, he was normally going to bed on the weekdays around 10 and waking up around 7. And the weekends, his bedtime was around 2 and waking up around 11. He also was known to be feeling depressed because getting poor grades in math, but was doing well in all his other classes. He never napped on the weekends, but always napped after school. Which diagnosis do you think is most likely correct? A, major depression, B, delayed sleep phase syndrome, C, idiopathic hypersomnia with long sleep time, or D, multiple sclerosis. Give you a few seconds to think about this. All right, so it is B, delayed sleep phase syndrome. So what really gives you that history is on the weekends, this 16-year-old boy is going to bed at 2 in the morning, waking up at 11 a.m. He can't do that during the week. because he has school, and this is where he's probably still sleepy at 8 a.m. and having trouble staying awake in math class. Probably gets better as the day goes on. And then on the weekends, he never naps, only naps on the weekdays. Very classic for delayed sleep phase syndrome. This is where an actigraphy or sleep diary would help you kind of see the patterns on the weekends versus the weekdays. Here we have a 32-year-old female, presents to the sleep clinic with excessive sleepiness that has been present for 15 years. She states that she feels dreams all night long. Also reports she has fallen asleep driving a few times per month on her drive home from work. It was after a second car accident. She did suffer a TBI at age 24. She also states she will take a nap in the afternoon, and she has a chance that the last 35 minutes is usually refreshing. She was started on a benzodiazepine as needed at age 30 due to mild panic attacks. Which diagnosis do you think is most likely? A, idiopathic hypersomnia with long sleep time. B, hypersomnia secondary substance abuse. C, narcolepsy type 2. Or D, hypersomnia secondary traumatic brain injury. All right. So this is most likely narcolepsy type 2. Why isn't it idiopathic hypersomnia with long sleep time? She reports a lot of dreaming in her sleep. Again, REM sleep is dysregulated in narcolepsy and not so much in idiopathic hypersomnia. We really don't get a true sense of how long she's sleeping, so it's hard to know for sure if she's a long sleeper or not. Hypersomnia secondary substance abuse, we really don't get a history that she's using anything. However, we will do a urine tox screen on her MSLT to make sure she isn't. And then D, hypersomnia secondary traumatic. She did have a brain injury, but it was after her second accident. So she was falling asleep driving before her TBI. So it really takes away, maybe the traumatic brain injury made things worse, but it really isn't the primary diagnosis. Thank you for your time today. Hopefully it was educational. I'm happy to take some questions.
Good afternoon, and thank you for attending the sleep track of the 22nd Annual JSM Educational Forum. My name is Brent Mayberger. I'm the Director of Partnerships with Medical Service Company. Dr. Roy, thank you so much for that outstanding presentation on emerging sleep therapies. I have the pleasure of moderating our Q&A session this afternoon, so let's dive right into some questions from the audience. So Dr. Roy, what can we as shift workers do to improve our sleep and circadian rhythm?
Yeah, this is a great question. There's not a great solution. So what our general rule of thumb, and I think it partly depends what the goal is. So is it a fixed third shift? Is it a fixed second shift? 3 days a week, 4 days a week? But what is the main kicking window? If it is what we typically recommend, if it's a third shift with a consistent schedule that's 40 days out of the 7, our rule of thumb is to try and encourage a maintenance of the sleep pattern 7 days a week, which is not usually very conducive to just normal day-to-day activities. People don't want to sleep during the day on their days off. But in terms of maintaining an adequate sleep circadian rhythm, the body prefers maintaining a similar schedule 7 days a week if possible. You can deviate 1 or 2 hours, but every day you're deviating your wake up time by an hour usually requires a day to recover from. Now, when you are sleeping during the day, we want to maximize that period. So have black shades, get rid of any phones or cell phones or any type of light. These factors that could be in the bedroom, and dedicate 6-7 hours if you can during that day window for when you're sleeping. When you're rotating shifts, there's really not a good solution there. Again, the body usually takes 2 weeks to adapt to a change in a shift. So if you've been nights for 2 weeks or 1 week, and then you shift days, it takes a good 2 weeks minimum, 10 days to 14 days for the body rhythm to adapt to that new pattern. So if you're flip-flopping, there's really no way to stabilize the circadian rhythm well. Now, we will use melatonin and light therapy to try to align to whatever schedule you're in, but it's not usually as helpful as we would like it to be.
Thank you, Dr. Roy. We are having some technical difficulties with your microphone, Dr. Roy. Is there any chance you can switch to your computer microphone? Maybe that will help.
Is that better?
It's better. Give me a test 1, 2, 3, Dr. Roy.
1, 2, 3, testing 1, 2, 3.
Okay, that sounds much better. Thank you.
Okay, sorry.
Okay, our next technology is great. So on for our next question, Dr. Roy. What is your center using for actigraphy?
Yeah, I know that.
Dr. Roy, I'm sorry. We are still not able to hear you. Maybe switch back to your earphones now. I apologize for the inconvenience. Still can't hear you, Dr. Roy.
No.
Getting bits and pieces, Dr. Roy. I'm sorry for the inconvenience here. Let's try that again. Test 1, 2, 3.
How about now?
You sound a bit robotic, Dr. Roy. I don't know
Okay.
if that's your connection. I'm not sure what's going on here, but we're working behind the scenes here to try and resolve it.
Is that better?
Yeah,
No.
let's try that, Dr. Roy. Again, apologize for
Okay.
the technical difficulties here. So, what is your center using for actigraphy?
So we're using the Condor device. I know we used to use the ActiWatch, but it's being phased out. And we're actually moving a little bit towards wearables too, and trying to have patients wear their Apple Watch or their Fitbit over weeks and seeing what their patterns are. There's some data out there suggesting that we might be able to determine a body rhythm or a pattern using wearables that are over the counter. But the Condor device is the main one we're using from an official actigraphy device standpoint.
Great. Thank you so much, Dr. Roy. All right, our next question from the audience. How would you handle naps for a patient on APAP?
So is that the MSLT we're referring to, or just naps in general? I
Naps
can
in
answer
general.
both. Okay. So our rule of thumb is if you are not going to sleep more than 20 or 30 minutes, we usually don't recommend using the APAP during that time. Now, we have a few patients who can't even sleep for 30 seconds without their APAP. But majority of patients, if they feel they're not going to nap more than 20, 30, then we won't encourage necessarily using it. But the patients that are going to sleep for an hour, hour and a half, again, we don't encourage naps more than an hour ideally. We will say go ahead and use your CPAP if you can. But if it's shorter than 20, definitely under 20 minutes, it's not something we're going to recommend use. And it also depends on location. If they're going to nap in their recliner versus their bed, we may be okay without going without their APAP.
Great. Thank you so much for that feedback, Dr. Roy. Our next question here, how do diagnoses such as chronic insufficient sleep or substance-induced hypersomnia affect the treatment of obstructive sleep apnea? It's a mouthful.
Yeah, so, I think the key is figuring out what's causing the sleepiness. And if patients with sleep apnea, about 50 to 60% will complain of sleepiness as a presenting symptom associated with their snoring, associated with their apnea. Of that group, 70% will respond to treatment, meaning their sleepiness will get better with CPAP, their sleepiness will get better with Inspire, dental, whatever. You treat their apnea, the sleepiness gets better. About 30% of people, the sleepiness is persistent, no matter how compliant they are on their therapy. It's that group you want to try to figure out what's causing their sleepiness. So is it insufficient sleep? How do we rule that out? We typically rely on actigraphy. Sleep logs can be helpful, but again, it's subjective. And if we really want to know, is this person sleeping 4 or 5 hours every night, the actigraphy should be helpful in that scenario. If it's sleepiness due to substance use, so is it due to medications they're on? Sometimes the history will elicit that, like they started on a beta blocker recently for their blood pressure. Now they're more fatigued, more tired. So it's sometimes challenging to separate some of this out, but it's just trying to take a careful history, and you should be able to delineate at least what's contributing. And sometimes it's multifactorial. It's not just going to be one, answer for that sleepiness.
Thank you so much, Dr. Roy. We've got time for one more question, and it is, what can respiratory care professionals look for to recognize signs of excessive sleepiness, comorbidities that affect compliance with CPAP and BiPAP machines, Dr. Roy?
So, we rely on the Epworth sleepiness scale just to kind of gauge how sleepy someone is. Patients who are very sleepy that fall asleep without their CPAP or BiPAP on is really a big challenge. And what we end up relying on is either a family member, a spouse, someone to try to encourage the patient, hey, if you're falling asleep in front of the TV, let's get you up to bed, let's get your CPAP on. Now, many of these patients are either alone or don't have that support system. The moment someone's feeling that sleepy, if there's some window of time that they're aware that they're going to be drowsy, it's usually then I'll encourage try to put it on. The second option we sometimes will use is have patients just wear it while they're watching TV, and the couch is kind of the most common scenario where people fall asleep and might sleep for hours before they go to bed. I sometimes have patients wear their CPAP while they're watching TV, and so if they do accidentally doze off, it's not the end of the world. They're kind of already on the treatment. But again, it's not always conducive. If they have glasses, they're wearing a full mask, it can get a little challenging. But these are, again, some of the tricks to try to overcome that. Again, the question is what's causing their sleepiness to get to that degree, and can they be more mindful of when they're starting to feel that drowsy?
Very good. Dr. Roy, we're actually going to circle back to the first question when we were having some technical difficulties there. Now that we've got those mic issues resolved, knock on wood, what can shift workers do to improve their sleep and circadian rhythm?
Yeah, no, so what I was trying to reference earlier is it depends on the schedule. So if they're a steady second shift, a steady third shift, are they doing 3 10s or 4 8s, or what is that schedule look like? The more stable it is, the more likely we can adapt to it. So if someone's sleeping consistently third shift 4 days a week, we're going to encourage them to be as close to that third shift schedule on their days off as well. Now, most patients are not happy when we tell them to try to do that. And deviating 1 or 2 hours is okay, but we want to be as close to their work schedule as their days off schedule. The challenging patients are the ones that are people that are doing shift work that are kind of flipping between second, third, first. And the ones that do that a lot, we see are in our region are typically factory workers. The Honda factory is a big one that we see patients come from. If they're on a rotating schedule, we try to encourage their managers and the scheduling team to try to encourage a forward rotation. So they go from first to second to third to first and move around the clock in a forward direction, because our bodies adapt typically much better to delaying our bedtime versus advancing. So this is why it's easier to fly west than to fly east, because our bodies can handle a delayed schedule much easier than an advanced schedule. Now, there are individuals that do better with an advanced schedule. This is a smaller percentage of people that are what we call advanced sleep phase. These are very clear morning larks. They go to bed by 7, 8 o'clock at night, waking up at 4 or 5 in the morning. That phenotype can handle a more advanced schedule. But most people are delayed, and most people are easier to shift to a later schedule. So if it's a rotating schedule, that's usually one of the solutions. Again, it's not perfect. And like I said earlier, we want to obviously do all the normal shift work hygiene. So, blackout shades, getting rid of cell phones, noises, white noise machine, dedicate a good 6-7 hours for that window of time to sleep during the day. And then we'll use melatonin in the morning to try to help them sleep during the day. Again, tricking the brain to think this is their sleep window, and exposing them to bright light while they're at work will help trick the brain to think the sun's out. So these are all things to try to adapt. Again, nothing perfect.
It's fascinating. Dr. Roy, thank you so much for your time and sharing your knowledge and expertise. Thank you to our attendees for joining us, and hope you enjoy the rest of the presentations this afternoon. So thank you again, Dr. Roy, and we look forward to having you back next year.
Sounds good. Sorry about the audio problem.
No problem at all. Thank you, Dr. Roy.
All right.